Welcome to This Explainer. Today, we're stepping directly into the ultimate clinical courtroom. Because, let's be honest, in medicine, especially when you're dealing with complex systemic diseases, the data you get is messy, it's chaotic. Too often, a clinical lawyer tries to make a quick, snap diagnosis based on pure static. But our goal today? We're going to act as the clinical judge. We're going to ruthlessly separate the definitive, undeniable diagnostic signals from the red herring noise. We're about to audit 3 high-stakes diagnostic dilemmas where trusting the wrong data point leads straight to a clinical disaster.
Okay, let's dive into this with a classic real-world scenario. You're looking at a 65-year-old patient who presents with an acutely swollen, red, incredibly hot knee. Naturally, your mind immediately goes to a 50-50 dilemma, right? Is this gout, or is it calcium pyrophosphate deposition, which we often call pseudogout? So, you order a serum uric acid level, and it comes back completely normal. So I have to ask, can you definitively rule out gout? Well, the answer might actually surprise you, and it perfectly highlights the profound real-world danger of relying on the wrong data point.
Here is our clinical docket for today. First, we'll look at crystal arthropathies and birefringence. Then, we're moving on to the lupus speciation axis. And finally, we'll break down the large vessel vasculitis matrix. Let's get right into it.
Case number 1, crystal arthropathies, and that classic 50-50 dilemma.
In our first trial, figuring out if it's gout or CPPD, the clinical judge absolutely will not accept a standard blood test as proof. No way. They demand a complete audit of the joint fluid under a polarized light microscope. It comes down to crystal geometry and optics. Take gout. It's driven by monosodium urate crystals. They are physically sharp, needle-shaped, and strongly negatively biofitringen. That means they shine a bright, unmistakable yellow when parallel to the microscope's slow ray. Contrast that with CPD, which is driven by calcium pyrophosphate. These crystals are rhomboid-shaped and weakly positively biofitringen, so they glow blue under that exact same light. That is your tipping point.
Just look at the sheer physical evidence here. On one side, you can see the absolute pathognomonic finding for acute gout, a sharp, needle-shaped urate crystal that has literally been ingested by a white blood cell. It's microscopic physics in action. Then, on the other side, we scale way up to the macroscopic view with an X-ray showing chondrocalcinosis. That calcification of the cartilage, that is the absolute, undeniable hallmark of CPPD.
So, circling back to our initial scenario, the absolute dumb mistake you have to avoid is ruling out gout just because the serum uric acid is normal. Why? Because during an acute, raging inflammatory flare, you've got powerful cytokine signaling that basically forces the kidneys to ramp up excretion of uric acid. Plus, the uric acid is literally precipitating out of the blood directly into the joint space. This causes the serum levels in the blood to artificially plummet. That blood test, it is pure, 100% noise. The true signal is sitting right there in the joint. You must treat the joint, do not treat the serum level.
And that brings us to a massive executional pearl. If you confirm an acute gout flare, you manage it with NSAIDs, colchicine, or steroids. But whatever you do, absolutely do not start a uric acid-lowering drug like allopurinol during an acute attack. If you suddenly tank that baseline serum uric acid, the crystals already inside the joint start to dissolve, fragment, and shed straight off the synovial lining. It is literally like throwing gasoline on a fire. It directly worsens and prolongs the entire acute inflammatory cascade. You have to wait 2 to 4 weeks after total resolution before you even think about altering their chronic baseline therapy.
All right, moving on to Section 2, the lupus speciation axis and the hepatic acetylation dividing line.
Our goal here is a bit of a biochemical detective story, differentiating idiopathic systemic lupus erythematosus from drug-induced lupus erythematosus, or DILE. The diagnostic dividing line here rests entirely on the hepatic acetylation axis. Think of this as the body's internal drug-clearing factory. Some patients are genetically wired as slow acetylators, meaning their factory works at about half speed. When they take specific medications like hydrazine, procainamide, or isoniazid, their liver just fails to clear the drug. The drug accumulates, and this specific metabolic failure artificially triggers an autoimmune, lupus-like state.
Now, what's really interesting about this antibody matrix is how cleanly it separates the true signals from the noise. In idiopathic SLE, your classic autoantibodies are anti-dsDNA and anti-Smith, and we all know the disease notoriously attacks the kidneys and the central nervous system. But in drug-induced lupus, because the trigger is purely pharmacological, the body forms a completely different marker, antihistone antibodies, which have greater than 95% sensitivity here. And crucially, This is the big one. DIL completely spares the renal and central nervous systems.
Which leads us to the next dumb mistake you've got to avoid. Do not rely on a screening anti-nuclear antibody, or ANA test, to tell these two apart. Honestly, it's basically diagnostic malpractice in this specific context. Why? Because the ANA test will be overwhelmingly positive, greater than 95% in both idiopathic SLE and drug-induced lupus. A universally positive result is entirely useless for differentiation. It's just more noise. You have to have the discipline to audit for those specific antihistone markers and look for that clinical organ sparing to actually find the truth.
Let's tackle our final case. Section 3, the large vessel vasculitis matrix and transmural architectural separation.
We need a fast binary mental model for large vessel vasculitis. Check this out. Giant cell, or temporal arteritis, selectively targets patients strictly over the age of 50. Geographically, it attacks the branches of the carotid artery, specifically the temporal, ophthalmic, and posterior ciliary branches. Symptoms? You're looking for jaw claudication, amaurosis fugax, and a soaring ESR, which is a massive red flag for systemic inflammation. Takayasu arteritis, on the other hand, strikes a totally different demographic, typically young females under 40. It targets the aortic arch and its primary large branch ostia, leading to asymmetric blood pressures in the arms, which is exactly why it earned the nickname pulseless disease. Patient age and specific arterial branch points, those are your absolute diagnostic tipping points.
Let's move to the severity matrix and see how this builds into real-time clinical execution. Step 1 is stable. A 30-year-old with asymmetric pulses but completely normal vision points right to Takayasu. You get a CT angiography of the aorta and start oral prednisone. Step 2 escalates to emergent. A 68-year-old comes in with a new headache, scalp tenderness, and jaw claudication. Suspecting giant cell arteritis, you immediately start high-dose oral prednisone and schedule a biopsy. But step 3 is critical. You suspect GCA, but the patient reports transient vision loss. This demands immediate hospital admission for high-dose intravenous methylprednisolone. You do not wait.
Which hammers home our final and frankly most severe dumb mistake: withholding systemic steroids because you're waiting around to perform a confirmatory temporal artery biopsy. Look, if the ophthalmic artery clots off due to that inflammation, the resulting retinal ischemia causes acute, irreversible blindness. You must administer those steroids instantly. This is literally how you save a patient's eyesight. And the kicker? The biopsy actually remains histopathologically accurate for up to 2 weeks even after you initiate steroids. Do not let procedural noise distract you from the blaring critical signal of impending blindness.
And that clears our clinical docket for today. Look, we all know the wards can be chaotic. It is so incredibly easy to be misled by a perfectly normal uric acid level, a universally positive ANA test, or the desire to get a perfect biopsy before giving life-saving medication. So I'll leave you with this final thought. When the clinical picture gets messy, will you fall for those noisy distractions, or do you have the discipline to step back and audit for the true signal? Thank you so much for joining me for this explainer. Now get out there and keep auditing the evidence.